Okay, I think we'll get started this morning. Welcome to Penn State College of Medicine's COVID-19 session on safety and anticipated rollout of the COVID-19 vaccine. This session is hosted by our Division of Internal Medicine. We thank you for your time and are delighted to have you join us for today's session. Our goal is really to engage you all in discussion that might address some of your COVID-19 vaccination questions and concerns. As you see, my name is Ellie, and I'll be facilitating today's session. A few housekeeping items before we begin. We have over 1,000 people registered for today's event. Because of this, we have muted participants to avoid any disruption to the session. We realize that question and answer time is very important. We have received many questions via email already and are trying to categorize and address as many as possible here. However, we will follow up with any open items after the session if we're unable to get to your questions. Please also note that no personally identifiable information is allowed if discussing specific medical cases. And finally, the session is being recorded. We do have a large team of monitors, or elves as I like to call them, who are logged in, and they are not afraid to put anyone on the naughty list. So we'd like to get this session started with an interactive and expert-led presentation to be followed by a question and answer period. However, please feel free to ask any questions in the chat as you have them. Erica Francis, if you want to wave, Erica and I will be moderating the chat, and we will get these questions to our presenters. You can also message us privately if you would prefer to ask a question anonymously. A special thank you to Drs. Jennifer Krasniewski, Cynthia Chuang, and William Kalo for organizing this opportunity, and to our presenters for offering their time and expertise today. And with that, I'd like to introduce Dr. Leslie Parent to get us started this afternoon. Dr. Parent is an infectious disease specialist and serves as Associate Vice President for Health Sciences and Research. She's Vice Dean for Research and Graduate Studies and is Professor of Medicine and Microbiology and Immunology. Thank you for joining us this morning. I'm officially passing the virtual baton to you to get us started, and I'll start sharing slides here.
Thank you so much, Ellie. I appreciate that very much. And thank you to all of you for joining. It's really very exciting to see the interest that this has generated, and we appreciate that you're taking time from your busy schedules to see us and hear the information that we'd like to share. This is the COVID-19 vaccine safety and rollout session. We're going to be hearing later on from Dr. Andrea Sakelios, Dr. Paul Haydet, Dr. Jonathan Nunez, and I'm going to start with just a very brief introduction about the activities that have been going on at Penn State Hershey and the College of Medicine since the pandemic began to affect us. So what are we doing to advance COVID-19 research? So many research has shifted their focus to COVID-19 in early 2020. As you know, at the College of Medicine and at Penn State Health, we have many physicians and scientists who are actively working on many important research projects, but they really felt as though they were called to serve the studies that were really important to advance our understanding of COVID-19. So we had over 100 projects that were in progress or were submitted for funding, 17 awards, and funded studies from external agencies, including the government. We have 2 projects that really focused on educating and supporting nursing homes in Pennsylvania to try to control and eliminate the spread of COVID-19 in that very vulnerable population. Another project that was recently funded to focus on helping community health workers address the COVID-19 situation in their communities. And we are currently working on planning a study that we could join of vaccine efficacy and safety in pregnancy, and another on blood thinners to prevent clotting complications of COVID-19. I would like to just highlight 3 particular studies and faculty members who are working in this area. Next slide, please. So Dr. Catherine Paulus is an infectious disease physician in the Department of Medicine, and she has really been the primary leader of several very important clinical studies that we have been a part of at Penn State. She began by becoming involved in the very first study that was sponsored by the National Institutes of Health, the National Institute of Allergy and Infectious Diseases, to test promising COVID-19 treatments using randomized double-blind placebo-controlled trials. As you realize, this was a brand new disease and we really knew very little about it at the beginning. Luckily, there had been some previous infections that were somewhat similar, and so some of that information could be used to jumpstart studies. So she really led a study on a drug called remdesivir, which was shown to be effective in a New England Journal article to shorten hospitalization of infected patients. She also then became the principal investigator of ACT 2, 3, and 4, and right now we're involved in enrolling patients in ACT 4. And so these are add-on studies, the remdesivir, and then added other drugs that could be used. And so we've been able to offer this to our patients in the hospital who have severe or moderate COVID-19 infections. And we really feel that that's important to be able to offer to our community the chance to participate in these studies, which could have an effect. And the second one on baricitinib plus remdesivir was just recently published. And so that is now in clinical use. So very important contributions, I think, to the treatment of this disease. On the next slide, please. In addition, we have some basic science faculty who are working on a project that was initially funded by the state of Pennsylvania to develop some new kinds of coronavirus vaccines. So this is a picture of Dr. Nick Bukovic at his bench working on this study. There are 8 faculty members involved, plus other lab technicians, students, and fellows in training. And they are pivoting to try to work on a way to predict design of vaccines that could prevent future pandemics as well. The next slide, please. The final person I'd like to highlight is Dr. Robert Lennon, who has really jumped on this ability to try to understand public health understanding of the disease and how people would intend to comply with public health recommendations. So he developed a survey that was then translated into 23 languages. He had responses from 50 states and over 70 countries. The findings were that there were changes over time in how the public consumed health information and differences in knowledge by the types of sources of information. He did find that there was a strong correlation between public health compliance intention and local disease burden. So for every 3% increase in compliance, there was a 9% decrease in COVID-19 cases. He has several publications on this topic and is currently exploring cohorts between countries to see how culture could impact the COVID-19 experience. In particular, he's starting to look at the results of surveys in China, India, and Turkey. Next slide, please. So to learn more, we do have a website called Pure that does allow you to search for publications and funding, and we have a special page on our COVID-19 research so that you could stay informed in what we're doing. So now I think we're going to turn to our speakers. And so our first speaker is Dr. Andreas Achilleos. He is an assistant professor in medicine in the Division of General Internal Medicine. Through his resident teaching, he is a leader in training future physicians in evidence-based medicine. One of his patients shared this about him: Dr. Achilleos is without a doubt the best physician I've ever had. My entire family goes to him and I recommend him to everyone. He is extremely thorough and intelligent. I feel comfortable knowing that I'm getting the best possible care from him. Our next speaker is going to be Dr. Jonathan Nunez. So I'm going to introduce everyone right now so that we don't have to interrupt later. Dr. Nunez is an assistant professor in medicine in the Division of General Internal Medicine, who is a primary care physician and also an infectious disease specialist. He's keenly focused on helping our most underserved patients, bridging the gap for patients with chronic illnesses and diseases like opioid use disorder. Dr. Nunez's patients say he is the best PCP they've ever had. He takes time to listen to everything. His explanations are thorough and easy to understand. And most importantly, they know they are being heard and they trust his judgment implicitly. Our final speaker will be Dr. Paul Haydet, who's Distinguished Professor of Medicine in the Division of General Internal Medicine. He also serves as a director in the Office of Medical Education Research. Dr. Haydet's patients shared that he is very knowledgeable and treated them with the utmost of respect. He listened carefully and provided quality health advice, resulting in an excellent visit. He's a very good practitioner, and they've never had a better person to treat them. So with those introductions, I'm happy to move on and introduce Dr. Kilios, who's going to start us off. Thank you.
Thank you, and hi everybody, thanks for joining us. So I'm going to talk a little bit about how vaccines work and some very basic data on the COVID-19 vaccine currently in use. So the basic principle of how vaccines work is like a boot camp basically for our body. So it teaches our body how to fight the real virus if it comes in contact with it. So the scientists have identified the key part of the COVID-19 virus being the spike protein, the thing that protrudes out of the surface of the virus. That's the protein that the virus uses to attach to cells. So that's also called an antigen. So we want to administer that to the body in some form to trigger a response, the production of antibodies that you can see surrounding the virus here that would ultimately block the virus from attaching and entering the cells. So that's the basic principle of vaccines, giving an antigen to produce an antibody response. So we have many different technologies or platforms nowadays that we can use to produce vaccines. The traditional platform is all the way to the left side. You can see where we give the whole virus either in a killed, inactivated form or a live attenuated form to the body, and we try to trigger an immune response. That's how traditionally most of the vaccines have been developed. The problem with this vaccine is because you're handling the whole virus, they require very large biosafety labs to be produced, so they're a little bit cumbersome in terms of producing. So instead, the scientists have figured other ways to trigger the same or even better immune response. You have a viral vector platform or technology where you use an innocuous virus like an adenovirus, which causes cold. You insert a piece of the COVID virus that produces that key antigen, that key spike protein, and you administer that to the body instead. Then you have protein-based vaccines where you basically produce the protein, the spike protein, the key antigen of the COVID in the lab, and then you administer that to the body. And the current vaccines we have available, both the Moderna and the Pfizer vaccine, are nucleic acid-based vaccines. So the scientists have basically cracked the code, the genetic code of the virus, so they can reproduce that in the lab and give instructions to your body, give that code to your body so that your own body now produces the antigen of the virus and then the antibody. So with this technology, the nucleic acid, you're not getting any piece of the virus administered to your body. Rather, you're giving the body the key instructions to do all the work itself. So how do we study vaccines to ensure safety and efficacy? Obviously, every vaccine starts with extensive research in the lab and then animal studies. Frequently, animal studies include different types of animals too, including primates who share similar biology with humans. And then all vaccines enter 3 phases of trials. So the phase 1, you have tens of volunteers, usually young, healthy volunteers, where you are looking for safety. You want to make sure that there's no major or common side effect that you see in that phase 1. In phase 2, you expand, you have hundreds of participants, and you're looking again at safety, but in that phase, you usually draw blood work to see whether the vaccine is producing antibodies. And that's not even enough for a vaccine to be approved. Then you have to go one step further, and you have to prove that even though it's safe and seems to be producing the antibodies, it can also prevent the disease in thousands of participants. That's where you have phase 3. The current phase 3 trials we've seen with Pfizer and Moderna included more than 30,000 individuals. So you go from the lab research to animal research, and then 3 consecutive phases of human trials to get the vaccine to the finish line. So how do we ensure safety along this process? Again, multiple trials starting from the lab to animals, then 3 phases of human trials. You include large number of participants, so even if it's a relatively rare side effect, it will come up. You have an adequate follow-up period. So the FDA requires that at least 50% of the participants in phase 3 trial are monitored for at least months before they can provide the emergency approval. Most of the side effects from a vaccine are seen within the first 6 weeks, so require most of the participants to be followed up for at least 2 months, ensures that we can pick up on all the major side effects. And the follow-up doesn't stop after the emergency approval. So they're going to continue to follow up those participants for up to 2 years. You have agencies that are independent of the manufacturers. Each trial has a data safety and monitoring board that has continuous access to all the safety information and can stop the trials at any point if they see any signal that indicates that the vaccine is not safe. And then you have the FDA with its own advisory committee that are independent of the manufacturers that look at all the safety data down to the medical records of the individual patients that had any adverse effects during the trial. And then you continue to follow up the participants, and even after the vaccine is approved, you have post-marketing surveillance. So our work is not done even after the emergency approval. So how do we check for the efficacy of the vaccine? These are some numbers, approximate numbers from the Moderna trial. So approximately, they had about 15,000 people approximately in the placebo group. They received the saline injection, and about 50,000 people in the actual vaccine. And over the course of their study, they saw 185 COVID illness in the placebo group and 11 in the vaccine group. So only 11 out of total 196 cases of COVID were seen in the vaccine, and that's how you come up with about 94% efficacy. They also looked at severe disease, which prompted the patients to be present to the hospital and be admitted, requiring oxygen. And they saw 30 cases of severe disease in the placebo group and none in the vaccine group. So there's a lot of concerns and perfectly legitimate concerns because of the speed that this is happening. We went from knowing the genetic sequence of the virus in January to now having a vaccine ready to be administered. And there's several reasons for that. Scientists had a head start because they've been trying to develop a vaccine against similar viruses. We had a SARS-CoV-1, the original SARS in 2003. Then we had a MERS virus, which is also a coronavirus, and the scientists were working on vaccines for those viruses. So they had a head start. Because of the unparalleled support from governments, pharmaceutical companies have been able to manufacture the vaccine at the same time that the testing was going on before they proved efficacy. And in the middle of a pandemic, you get a lot of people who want to volunteer and participate in a trial. So we were able to recruit more than 30,000 people for these trials very quickly. And because of the same reason, being in the middle of a pandemic, unfortunately, we have a high number of cases. but that high number of cases facilitates the vaccine trials because the more cases you have, the earlier you're going to show some efficacy. I showed you the Moderna trial, 196 cases. They were able to get to those cases within a few months. If it was any other infectious disease that is more rare, it would take years sometimes to accumulate that number of cases to be able to show that the vaccine is effective. So do we know everything? In science, we never know everything. There's always things we need to know. The correct question is, do we know enough? Do we know enough about the safety and the efficacy of this vaccine to approve it? And the answer is yes. There's obviously things we still don't know. We don't know if it prevents transmission of the virus. So there's still a possibility you get the vaccine, you don't get sick yourself, but you can carry the virus and transmit it to somebody else who may get sick. So data are accumulating on that regard, and we may have some information soon. Will somebody need a booster? We don't have an answer for that yet. It seems that the immunity from the vaccine will last at least a few months, and we all hope more than that, but we don't know for sure. It also depends on potential mutations of the virus. So what's the chance of a serious side effect not yet discovered? So by including at least 30,000 people in these trials, you have a pretty good chance of identifying serious side effects that can happen in up to 1 in 10,000 individuals. Now, if it's a side effect that happens 1 in 50,000 individuals, 1 in 100,000 individuals, you may not be able to discover that in those trials. That's why you do the post-marketing surveillance that the FDA is currently doing. So how do different subgroups of the population respond to the vaccine? Again, we don't know everything in that domain. I'm going to talk about a couple of subgroups because we had questions on that. So in terms of pregnancy and breastfeeding, pregnant women were not included in these trials. Some women became pregnant in the course of that trial, and we didn't see any adverse effects on those. Moderna has also submitted animal studies that don't show any ill effects on pregnancy. Based on what we know about how this vaccine works and how other vaccines are tolerated during pregnancy, we don't anticipate any problems with pregnant women receiving these vaccines. The current recommendation from the American College of Obstetrics and Gynecology is to treat pregnant and breastfeeding women the same as the general population in terms of prioritizing them for the vaccine. And when it comes to immunosuppressed individuals, we're still waiting more data on that. Based on how the vaccine works, we don't anticipate that immunosuppressed individuals will have a higher risk of adverse effects than the general population. The only concern is whether they get the same immune response to the same level with the same benefit as the general population. So we're still waiting data on that. So still a lot to learn, but I think we know enough to put those vaccines forward and advise the population to be vaccinated. Thank you.
So thank you for the opportunity to speak this afternoon about such an important topic. I do want to mention my goal is to kind of try to introduce to everyone the concept of the thoughts of allocation and how some of those decisions for certain groups are being made and proposed. And a lot of information is also coming from the Centers for Disease Control as well. I'm not part of the planning within our health system. I'm not part of the planning within the Department of Public Health. As I anticipate, there are many specific questions that have been asked in the last month and a half as I speak with patients, especially for when the vaccine will be available for certain groups. So I may not be able to answer all those questions. I apologize. But I would like to provide a brief update where we are in Pennsylvania with COVID-19 as we prepare for the holidays. You know, as we review the recent months, the number of cases that were represented in the figure has been rising. And on the left-hand side, we see number of cases. On the bottom, we have months. And what I want to show is that we're steadily increasing since mid-October, which is really highlighted in the orange box. Next slide, please. So as we're seeing a rising case count, we're also seeing a steadily increase in hospitalized patients, which is highlighted on the left lower figure with the blue star. And as expected, with an increasing amount of hospitalizations, we're also seeing a rise in severe cases, highlighted with the yellow star, that are requiring intensive level care, commonly referred to as ICU level care. And as we look into the state, many areas affected by COVID-19, we are seeing a significant amount of disease in the local community. Next slide, please. So since the pandemic, organizations such as the Advisory Committee on Immunization Practices have been holding meetings publicly to continually review the data of COVID-19 in the US and vaccines in the development to help prevent COVID-19 disease. And as they make initial goals for vaccination recommendations, they review the data on candidates receiving the vaccines in studies looking at age, race, ethnicity, underlying medical conditions, how different groups responded to vaccine, and side effects experienced. The initial goals for vaccine recommendations have been made, preparing initially for more limited supplies. The goals are to ensure safety and effectiveness of COVID-19 vaccines, decreasing death and serious disease as much as possible while reducing transmission, preserving functioning of society, which means helping to minimize disruption to society and the economy while maintaining healthcare capacity, which refers to the ability to continue to care for patients, and ensuring equity and vaccine allocation and distribution. Next slide, please. So as we think about vaccinating, we're looking at supplies of vaccine and availability changes. It remains a balancing act to best prevent mortality, safety, effectiveness, social functioning, while trying to balance the equitable allocation of vaccine. Next slide, please. As more vaccine becomes available, what population should be added successfully will change to the priority list of recipients. And as these decisions are being taken into account, factors to those decisions include reviewing populations that are most affected, individuals at higher risk, so elderly and underlying health conditions, occupations at higher risk, healthcare workers or frontline workers, populations at higher risk, racial and ethnic groups, residents of nursing homes. We have to continually balance goals, right? Preserving morbidity and mortality versus preservation of societal functioning. So on the left is the proposed phases of COVID-19 vaccination provided by the Centers for Disease Control and Prevention and the Advisory Committee on Immunization Practices. And as we balance allocation using science and ethics with limited supplies of vaccine, many are proposing rollout of vaccine by highest risk groups first. So as noted on the right, phase 1A, so they're being referred to as phases, and the implementation thought process is that it will be slightly lagged a little bit by each phase. So looking at phase 1A, we think of residents of long-term care facilities. Because of the communal nature of nursing homes and long-term care facilities and the population served, generally it's older adults with underlying medical conditions. They're at increased risk of infection and severe illness from COVID-19. And research has suggested that healthcare workers faced increased risk of coronavirus exposure and infection when compared to the general population. So thinking of other groups most affected, people who are 75 or older, or other frontline essential workers such as firefighters, police, teachers, should be next in the line to get COVID-19 vaccine due to the increased risk of transmission or the severity of disease. In addition, the federal officials anticipate having enough doses to immunize around 100 million people in the US by the end of February of 2021. That's the goal, which is remarkable as we think about that's about a third of the US population. Next slide. So the estimate of essential workers is estimated to be nearly 90 million. So frontline essential workers on the left is nearly 30 million, and it includes all types of profession, first responders, educators, transit workers. There's other essential workers, which is estimated to be nearly 60 million, and include other occupations as well. As we think of workers, other things to consider is setting of work, if it's outdoor, indoor, proximity, how close are they to other workers, type of contact, duration of interaction, number of contacts, employee risk factors, such as underlying medical conditions. Is there screening protocols to protect workers? There's a lot of thought process that's been trying to go into this. Next slide, please. So I'm not trying to scare anyone with the figures. I'll just try to focus on what's important. So when we look at these initial recommendations, let's take a moment and review some of the science. So as we look at this figure, what we see on the left-hand side is age groups, and on the bottom is death rate. or the ratio of deaths to the population. And I want you to notice that the risk of death increases with age. The greatest risk for death from COVID-19 is among those age 85 or older, but rises dramatically in those greater than 65 years of age. And moreover, 25% of COVID-19 associated hospitalizations are in persons greater than 75 years of age. Next slide, please. So other factors that can increase risk for severe illness and hospitalization are underlying medical conditions. So as we look on the figure on the left, what we'll see are several common medical conditions and an estimate of the risk for hospitalization and COVID-related disease. And the farther the dot and line goes on the right, the higher that medical risk factor, also referred to as an underlying medical condition, is associated with hospitalization and COVID-related disease. And when we look at the risk of hospitalization with increasing number of medical conditions, as highlighted in the orange box on the right, the greater number of medical conditions associated with increased hospitalizations, ranging from anywhere from 2.5 to 5 times more likely. Next slide, please. As we look for risk of workers, some of the data is provided about what we learned from the first waves of the pandemic in large cities such as New York City. And the study looks at percent of workers in public service jobs for May to July that were seropositive for COVID-19. Now, you have to interpret that with some grain of salt. So when we're looking at seropositivity, we're trying to estimate the amount of workers that may have been exposed to the disease. And as we make immunization recommendations, one consistent trend is that some workers are more at risk at others. And in the study, we see that other frontline workers are and remain in high risk of disease. And some of these jobs are very important to the functioning of society and or requires interactions with people on a continuous basis. Next slide. Okay. So the recommendation in changes are occurring. So even as recent as last weekend, the ACIP and CDC have continuing update recommendations for vaccinations as we are involved in the rollout of vaccines. So as more vaccines are available, currently phase 1A, which some hospital systems have started within the last week, are providing vaccines to healthcare personnel and long-term care facilities. And as COVID-19 vaccine becomes more available, the thought process is that each rollout, which may occur at some point, to offer them vaccines. So when we look at the next phase, patients aged 75 years or greater, other frontline essential workers, and phase 1C, persons aged 65 to 74 years, persons aged 16 to 64 years with high risk medical conditions, and other essential workers. It's hard, working with it as a primary care provider, I want to offer everyone the vaccine. And eventually I think we will. But I think at the moment, as we have a limited amount of source, we have to try to keep our community that is at higher risk safe. Thank you.
So here we are. We now have a vaccine for this thing. And eventually we're going to have enough supply of vaccine for everybody who wants it to get it. But right now we're in the darkest part of the night before the dawn. We still need to stay safe until everybody can get vaccinated. And what I'd like to do is, for those from my generation, I'd like to show you a clip from a shampoo commercial from the 1970s. Have a look at this.
And shampoo.
You'll tell two friends, and they'll tell two friends. Now you got it. And so on, and so on, and so on.
Fabergé organic.
Yeah, that's how COVID spreads. And notice she's telling friends. She's not telling the random person at the supermarket. Sure, you can get it from the random person at the supermarket, but we're talking about different levels of risk here. And there are 4 questions you can ask that can tell you how risky a situation is. and I'm putting these in the chat box as well, because these are critically important. Asking these questions is what's going to keep you safe. If you're going to do something, you've got to ask the 4 questions. Number 1, how close will you be to other people? The closer you are to other people, the riskier it's going to be. Number 2, how many people will be there and where are they coming from? The more people there are, the riskier it is. The more people from the more different locations, the riskier it is. So going to work is risky because you're working with a bunch of coworkers who are all coming from different households. Number 3, how long will you be in the space and will you have a mask on the whole time? So going to the supermarket for 15 minutes is much lower risk than going to church and staying for an hour. And that's lower risk than going to a restaurant and taking your mask off for an hour around a bunch of other people in the restaurant who are also taking their masks off. And number 4, how enclosed is the space? Going for a walk in the park, staying away from other people is relatively low risk, whereas staying in a single family home with limited ventilation in the wintertime with all the windows closed is higher risk. Okay, next slide. Let's try this out. I have been talking to patients, I've been talking to everybody I can to try to get them to take safe behaviors. This was texted to me by a friend of mine in the last week. Quote, we're going to be super safe. We'll have only 10 of us. My sister and her family, my son and his fiance, myself and my girlfriend, all masking and ordering food from Bob Evans for breakfast. 3 of the group have already recovered from COVID. We'll only be together for breakfast and a gift exchange, probably less than 2 hours. I'm being very careful these days with mask, hand sanitizer, and anything I touch. I would invite folks to use the 4 questions and tell me, is this low, medium, or high risk? Put it in the chat box. Go ahead right now. Low, medium, or high risk? Okay, the highs have it, although we have some medium highs and some medium. Here's how I would break this down. How close will you be to other people? Probably very close, because it's not going to be, it's going to be hard not to hug, and it's going to be hard to stay 6 feet apart with 10 people in a single family home, especially if you're in the same room. Number 2, how many will be there? 10 people from at least 3 different households, and if my friend and his girlfriend are from 2 different households, that makes 4. Number 3, how long will you be in the space? Well, he indicates at least 2 hours. And if they're going to eat breakfast from Bob Evans, they're going to have to take their masks off to eat. And how enclosed is the space? Well, probably very enclosed in a single family home that has low turnover ventilation. Bottom line, this is high risk. So here's the deal. I've been hearing, this was from a friend of mine. And I would say, knowing this friend, 3 of the people at this gathering were physicians who should know better. So this is me being very school marmy. What I would like to invite and ask you to do is to turn the shampoo commercial on its head against the coronavirus. Tell 2 friends and get them to tell 2 friends. If you value your friends and your family, stay home. Use your influence with your friends and family to get them to ask the risk questions and to stay out of high risk situations. We physicians cannot do this alone. I believe it is our civic duty. Please help us to help people stay safe until we can all be vaccinated. Thank you.
Well, thank you so much to our speakers. We have had a flurry of questions come through chat. And like I said, we do also have a lot of questions that are coming in prior to this session that we'd like to address if they haven't already been addressed in the presentations. If I can, I'd like to start with some direct messages that I've received throughout the presentation, just so I don't miss them. If one doesn't get the vaccine now, when will it be available again?
As I've been mentioning to everyone, I think one of the big things is trying to figure out how much allocation we're actually getting. So this is the first week that we've, in our hospital system, that we've received vaccine. So the first batch has been Pfizer. I do think the availability will change on what the continual supply will be as we're provided with more vaccine. The other question that I usually get asked is which vaccine, and one of the things that might be is also which vaccine is available. I do anticipate in the coming months that some of the vaccines that we're providing will be the Moderna vaccine.
I have another direct message. Will vaccines be effective if patients who test positive for COVID antibodies?
So the thought process is that it should be. I think there's a lot of, when we're looking at antibody testing, I describe it as being in the wild, wild west. And I think as I look and interpret the results, sometimes I have to interpret it with a grain of salt because there is some cross-reactivity with other types of viruses, including other coronavirus. But long-winded answer to your question is it should still be effective.
If I'm understanding correctly, the vaccine will not prevent COVID-19, but rather lessen symptoms, hospitalization, and death. Is that correct?
So we do believe the vaccine prevents the disease having any symptoms to a significant degree. We don't know if it prevents the asymptomatic carrier. So that's what we're trying to figure out now. That's what we're waiting more data on, but we are very optimistic that it would reduce significantly the prevalence of asymptomatic carriers too. But we do have confidence that it decreases the illness, the COVID illness, by 95%, as we discussed.
Okay, I'm going to go to some questions, and bear with me here. I'm going to kind of skim these that I've pulled together and skip the ones that I know we've already answered through presentation. But I'd like to get some of these submitted questions answered as well. Someone had asked in an email, can we choose which vaccine we want?
That's a great question. At the moment, I cannot say that we can. I think part of it also might be what's available. I think if we have a number of vaccines in the future, we may be able to. I also think one of the big things to remember between the two differences of those two vaccines are how they're stored. So I do think some institutions where they can't necessarily refrigerate the Pfizer vaccine to the requirements that it need may be only offering Moderna. But I think we'll learn more, as we get more vaccine.
How long does the vaccine protect us? Will we have to get it every year?
So we don't know the answer to that yet. Moderna has published trials that show that the levels of antibodies that we want are maintained at least for 3 months after the second vaccination. So we hope that immunization is going to be long lasting, but we're still waiting data on that. That also depends on whether there is any mutation of the virus that makes it resistant to the vaccine, which we haven't seen yet. So short answer, we don't know yet. We are hopeful, but we don't know for sure.
So I have another question here. A lot of people are wondering how they would get the vaccine. Is this something they would have to go to their primary care provider? Will CVS or Rite Aid have the ability to administer a vaccine? And at what point will that happen, and will they be notified?
I'll do my best to answer that. I think it's a wonderful question, and I think a question that I've been answering almost every day for the last couple of weeks. As Paul mentioned, I always touch base with my patients at the end of our visits. What are you doing for the holidays? Let's talk a little bit about vaccine. The timeline, we're not necessarily sure, right? I think for some of the institutions, we just got vaccine to start offering for our highest risk groups. I do think the rollout will depend on how much vaccine we have, and as well as the uptake and use of that vaccine. I think as we plan to try to vaccinate larger communities, we do need to think about partnerships that might have to be established to reach those communities. So I do think that one of the things that the local health departments and state health departments are planning is, there might be other providers that might be certified to give these vaccines, or start thinking about pharmacies to roll out some of these vaccines. I think it's still going to be challenges to reach those pockets of patients where they're a little bit farther away from an urban center.
We've received some questions from folks prior to this session that have been diagnosed with COVID-19. So they're considering themselves a long haul COVID-19 patient, and they're still experiencing post-viral symptoms after the infection. So how much risk is there that the vaccine will cause that person to relapse or their symptoms to worsen, as they believe it may have happened with the flu vaccine this fall, albeit short term? Is there a risk there?
So in the both in the Moderna and the Pfizer trial, they had a small number of participants who had evidence of previous immunity. They were not long haulers, they were not symptomatic, but they had evidence of previous immunity. And they did see a small number of reinfections on those individuals. So you could have a reinfection with the virus, and that's where the vaccine may protect you. In terms of exacerbating the symptoms based on how these vaccines work, I doubt that would be a concern, although that wasn't specifically looked at in the studies.
There's a question about serious allergic reactions. What would be considered a serious allergic reaction that might happen if you get the vaccine?
So I think the hard part is, when we look at these allergies, sometimes we don't vaccinate communities that would really benefit from it. So when we're looking at this, it doesn't necessarily rule out providing the vaccine, but what we think about when it's a severe is when we think about like an anaphylactic reaction where someone's having such a reaction that they can't necessarily breathe. That would be considered a high risk. And even on that, I think there has to be some thought process of, was it really the aspects of the vaccine? The thought process for some, it might be the polyethylene glycol, if I remember correctly when in my review. But what we've been doing for patients, even after getting, well, let me rephrase that, not myself, but what they've been doing for patients after they get a vaccine is monitoring. So there is a period of time when we provide the vaccine that we're being monitored for at least 15 to 20 minutes.
So I believe these next two questions could probably be answered pretty quickly and may have already been answered in the chat, but I think it's important for the recording when we go to share it with the community later. Just a quick question. Can you let us know if the vaccine contains a live virus? And I think Dr. Achilleos covered this, but I'd like to just make sure we get that answered.
No, the current vaccines, Moderna and Pfizer, do not contain a live virus.
Great. And I think Dr. Krasniewski answered this in chat as well, but is the vaccine safe for children? Will they be getting the vaccine?
So right now for the tiers, the vaccine studies, and even Andreas or someone else can add this too, they haven't really been studied in the pediatric population. So right now it's being offered if the plan for the tiers is above the age 16 with an underlying medical condition.
Erica, can I ask you to unmute and maybe address some of the questions that weren't answered in chat?
Yeah, so I'm looking through right now. It looks like several of them have been answered. We did have a bunch of questions asking about how they would understand when and how they were eligible and where to receive those. So I'm scrolling back down through. I know that our experts are busy answering some questions as they go. So there was a question about thoughts on how the mutated strain out of the UK will impact vaccine efficacy. And I know that there was another question as well asking about, will the vaccine cover multiple strains?
Yeah, I don't think we have a full answer on the strain from the UK. I think most scientists don't believe that it's going to affect the efficacy of the vaccine, but they're still analyzing data, and hopefully in the next few weeks we'll have a definitive answer. In terms of covering different strains, it depends how the virus will mutate. If it mutates significantly, especially the spike protein that is the target of the vaccine, then it may not be covered. But right now, so far, we haven't seen any mutation significant that will impact the efficacy of the vaccine, and we hope it stays that way.
I echo what Andreas was mentioning. I think one of the things to remember for this type of virus is there is expected changes to occur. There's tiny genetic modifications that occur with replication because it tends to be like a sloppier virus. But the thought process is the genetic course should be the same and the vaccine should be about the same. And all the stuff that's been coming up with how it's more infectious, I think a couple caveats to that is some of that's been based on mathematical modeling and not necessarily like lab data. And the flip side to it too, when you look at some of the other countries, and I think some of Dr. Lennon's research has shown this too, is some of it might be affected because we're so long into the pandemic that we haven't been as stringent on the isolation and quarantining. So that might be another factor that's contributing to it.
I have a direct message here. If a provider gets vaccinated and shortly thereafter has a fever, will that provider have to quarantine and be tested for COVID-19?
That's a wonderful, great question. And I think overall, if there's the thought process that they have been vaccinated and know that that was a thought process, most likely not. But I always touch base with the excellent employee health. But I do think like there is some expectation that there might be an illness in following the vaccination.
Once you receive a vaccine, how can you be sure that you're one of the 95% of people it will work for? If you go to the antibody test, go get the antibody test done, should it show antibodies and you know you're covered, or how can you be sure?
So for the time being, we don't have a way of making sure, but I think at some point there may be, yes, tests that will detect a sufficient level of antibodies that will ensure you're immune, but that's not currently recommended.
I have a question in chat that I believe goes along with Dr. Hayditz's case that he presented. If someone has recovered from COVID over 2 weeks ago, is there a concern that they can still transmit the virus?
Oh, that is the $64,000 question, isn't it? Yeah, so I'm going to say something, and then I'm going to open it up to JJ and Andreas to contradict me. Nobody knows completely. It is known that people can still remain positive for many weeks to even months after having COVID. The big question is whether they're shedding active infectious virus particles or not, and that is less known. There is the possibility that people can keep shedding active virus, although it is pretty low. the CDC recommendations are that once somebody has been fever-free for 3 days and more than 10 days from the onset of symptoms and are getting better, that they should have low infectivity at that point. But it really is an unanswered question. JJ or Andreas, what would you add to that?
I mean, I can address it too. So Jonathan, feel free to,
No, please, please.
the studies have looked at whether the virus could be cultured after certain periods of time. And so you're right, you can still detect it with the PCR-based testing, but the vast majority of people are not infectious after 10 days. And so 10 days is kind of the cutoff for when we feel safe to say that you wouldn't be infectious, unless someone is severely immunocompromised. And so in that case, they extend it to 20 days just to be on the safe side. You're right in that there haven't been a large number of studies, but those studies that have been done have given us that much information. Jonathan, do you have anything to add?
No.
So we have a question here in chat. Do we know the long-term effects of the vaccine? Some of this person's family is reluctant to get the vaccine because they're worried about the possibility of long-term effects. What are the chances of long-term effects with the vaccine?
So as I indicated in my presentation, we don't know everything. So there's still a possibility, low level of possibility that there may be some side effect that we have not seen in the trials that we have conducted. Based on the mechanism of how this vaccine works, and the nucleic acid that we're injecting gets basically disappears from your body very soon. And also previous knowledges from vaccines that most of the side effects will appear within the first 2 months. And we have enough data within that period of time. We don't think we're gonna have a high risk of unanticipated side effects, but that's still obviously part of the surveillance, and that's why the patients in the studies will be monitored for 2 years, and all the patients who receive the vaccine currently under the emergency use authorization will also be monitored and be able to report any adverse effects that we can hopefully discover.
There's a couple questions in chat that are asking about whether or not cancer patients should receive the vaccine. There was also one that someone mentioned her husband just had surgery, and should he wait a specified amount of time before receiving the vaccine?
As Andreas was mentioning, I think overall the thought process, even if for some of our patients who are considered to be immunosuppressed, so that's what we think about with our cancer patients or certain medical conditions. In theory, it should still be safe to get the vaccine. The question that comes up is how effective it's going to be. So like I do describe everyone, even with the vaccine, unfortunately, the masks aren't going away in 2021. So I will still continue to provide some of the excellent guidance and precautions that Paul had mentioned in his talk as well.
There's a few questions about when each of the different tiers or phases of vaccine distribution, when folks that fall within those groups will be notified, and how will they be notified? Is there a way that they can get on a listserv? How will they know when they're eligible for a vaccination?
I think as I mentioned earlier, I'm not part of the health system planning as well as the local and state health department planning. I do anticipate that this is stuff that's being addressed. So one of the big things I mentioned is what I say today may change and will probably change within 3 days from now. But I do think this is something that we're actively working on. So I don't have a direct answer for that.
Okay, I think that covers a lot of our chat questions. We will certainly, as I mentioned in chat, pull together a frequently asked questions sheet that includes questions that were submitted prior to this session and during the session in the chat, and we'll make sure that we provide that to you, as well as a PDF of the slides for this presentation and a link to the recording, so that if it's something that you'd like to revisit or share with family, you can certainly do that. So I just want to thank you all so very much for attending today's sessions. Thank you so much to the experts who have given their time today. We hope we were able to answer your questions. Like I said, we will follow up with additional resources. Feel free to email echo@psu.edu if you have any additional questions or concerns that we were unable to get to today. Happy holidays, everyone.